rectal cancer treatment. And I don't know whether or not you have heard about transanal rectal cancer surgery, TaTME, which was actually one of our major areas of interest in terms of rectal cancer surgery over the past 6 years in Berlin. And it was a very interesting time because, and I'm going to show you that in a minute, back then the discussion about open or laparoscopic surgery in rectal cancer treatment has at least been settled in terms of the results of some prospective randomized trials. And exactly at that time, two new methods came up. One is obviously robotic surgery, and the second one was the TaTME. And since the robot at that time was highly debated in Germany, we had some experience with robotic surgery at the Charité, but mainly used it for thoracic surgery and upper GI surgery. And for colorectal surgery, a colleague of mine, Felix Eigner, who came with me together from Innsbruck to Berlin, and myself had started a year ago with an international working group working on this nodes approach of transanal surgery. And it had raised quite some interest, at least in Germany, over the past years. And I'll take the opportunity to summarize our experience with that. And so the title of my talk is not a coincidence. Does it make sense? Because you know, the technique has been highly debated, and we will see what it contributes to the armatorium in rectal cancer surgery. Having said this, I have to acknowledge that I received some educational grants and honoraria for TaTME courses from medical companies over the past 7 years, which will not at all affect my talk, but I want to disclose my conflicts of interest. And when we talk about rectal cancer surgery, you know that the facial boundaries of the deep pelvis had been quite poorly defined prior to the past 10 years. And actually one of the things that everyone profited from the technical innovations and the interest in these surgical techniques was that the surgical anatomy of the pelvic floor had been very thoroughly studied, and in some extent the textbooks had been rewritten. And what we're going to talk about now are mainly the very low rectal cancers, like here type 1 and type 2, which are very close to the levator muscle and the linea dentata, which, however, from an oncologic point of view, would allow a sphincter preserving operation rather than these even lower rectal cancers like type 3 intraanal and transanal, type 4 types of cancer, which of course require an abdominal perineal rectal excision. I apologize for this slide. This is just the German guideline, which says that for rectal cancers of the middle and lower third, the total mesorectal excision, or TME, is the standard approach, which is to some extent important because coming from what we had learned or the experience we had gained from nodes, it had not been clear whether or not a transanal approach might be appropriate for only low pathologies of the rectum, which require a TME, or probably for cancers of the upper rectum, or even for sigmoid pathologies. And this at least had been settled, I think, about 7 years ago, when it turned out that whatever you do from the transanal side and from below always relates to pathologies which would require a TME and therefore a very low anastomosis, because as you know, the functional results are clearly correlated with the amount of rectum preserved above the dentate line. So a very low anastomosis is, from a functional point of view, always worse for the patient than a higher anastomosis, and therefore everything we discuss right now only relates to patients who really require an ultra-low anastomosis. We also know for decades that the circumferential resection margin and the preservation of the mesorectum highly correlates with the risk of recurrence, as summarized by this paper from 2008, which clearly shows that a wide CRM leads to a quite appealing local recurrence rate of 6% after 3 years. And if the circumferential margin is flattened, the local recurrence rate is about 2 to 3 fold higher. So this is one of the key things we have to keep in mind dealing with rectal cancer surgery. And I mentioned that in the past 10 years, we finally had some studies who revealed that open surgery is especially problematic for very low cancers, as demonstrated here in the multi-center Color 3 trial. And you see it compared the CRM and the local recurrence rate between laparoscopic and open surgery, which was pretty much the same for all rectal cancers. It was the same for the proximal rectum and the mid-rectum. However, we have a problem in the distal rectum. And the CRM positivity rate was more than 20% in the open group. It was 10% in the laparoscopic group, and the local recurrence rate was also 3-fold higher in the open surgery group. So that was a strong argument for dealing with these pathologies laparoscopically. However, and every one of you knows patients from either side, the pelvis is not the same in every patient. And on the right side, I have to admit, this is not a rectal cancer patient. It's a lady with a rectal prolapse, but you directly see from the umbilicus to the pelvic floor. While in this male patient with a bulky mesorectum, you see nothing at all, and you don't see the cul-de-sac and not anything from below. So of course, in patients like these, it is highly problematic to reach the pelvic floor. And if the tumor is in the lower third of the rectum, the most difficult part of the operation is also the most delicate one, because you are working around and very close to the tumor. And for long, it has been stated that the distal rectum is difficult in laparoscopic surgery due to numerous reasons, which are outlined here: the exposure, the trocar positions, which might hamper you to work with straight instruments down the promontorium, the limited possibility for retraction if you have to handle a very bulky tumor, or a fatty voluminous mesorectum, a narrow pelvis, an obese patient, or a tumor which is very close to the dentate line. And also for these tumors, although it is always reported as the standard to staple the rectum from above, it's very difficult to define the distal resection margin and to technically reach a clear cut. And we all know the data that the number of staple cartridges you need to transect the rectum close to the pelvic floor directly correlate with the anastomotic leakage rate whenever you need more than 2 cartridges to transect the rectum. And having said this, even in the named studies, the conversion rate from laparoscopic to open surgery was 1 in 8 patients due to these limitations. So we clearly have a problem to laparoscopically finish rectal resection if the patient does not have a favorable anatomy. And on top of that, these are data from the German registry, which simply records all colorectal surgeries. And as you can see, the rate of definitive colostomies in patients with tumors of the distal third is about 30%. So 1 in 3 patients will receive a rectal amputation because it is too difficult to anastomose. And again, patients with type 1 and 2 cancers would theoretically deserve a chance for preservation of the continence and avoidance of a definitive colostomy, which is simply not possible with the techniques we had available 10 years ago. And even if you complete the transection, the mesorectum doesn't always look like this, which is probably an example of a complete mesorectum, but we see that there are very many areas where you could either produce a hatching of the mesorectum or leave behind some edges or simply miss out some parts. And there was a very regarded MRI study which was published in 2013. So it was mainly concerning open resection and laparoscopic resection. And they found that in 36% of the patients who theoretically would have received a complete TME had rests of the mesorectum still in place. So the quality of the resection is far from perfect if 1 in 3 patients is not resected the way we always state that we treat the patient with rectal cancer. So, and I mentioned that it was a very interesting time because people asked, how could we do better? And 2 major ways approach. One is the robot. And for today, I beg to excuse that I'm not elaborating on the robotic approach, because that's a different story, but at least in Germany and in Austria, the robot has gained that much momentum that it will probably be the preferred technique for low rectal cancer resections in the future. While the second way is what I'm going to summarize right now, the transanal approach, which basically, as you can see here, combines an abdominal resection phase, as we know it from open and laparoscopic surgery, combined with a transanal approach to transect the rectum and just complete the lowest part. The rationale for the TaTME, for the transanal TME, is therefore that when you have a patient with a 90-degree angulated os sacrum, which is basically the place, the situation in every slim and for sure every male patient, you have 2 phases. You have one area which goes down from the promontory to about S2 to S3, which can be reached quite nicely with straight laparoscopic instruments coming from the usual port sites as we know it in the lower abdomen, while the second part, which is the lower third of the rectum, can be terribly hard to access because you have these 2 lines and you can only access the pelvic floor by angulating and basically pushing the anterior compartment of the pelvic organs upwards. And the theory of the TaTME is not that you replace the favorable abdominal phase, but that you use the transanal access to combine it and do the most difficult part from an abdominal phase, the lower part of the rectum, in a way where you also have a straight dissection line. And you see that having said this, you theoretically exactly know where both dissection lines should meet. You should not go up to the promontory with the transanal approach, and you should not go down to the pelvic floor with the abdominal dissection line, but exactly the meeting point would be around S2, S3, where both lines start going straight around the rectum. And this idea of a transanal approach was not a new idea in the 2010 years. It started more than 30 years ago with the development of transanal microscopic surgery, which started in Germany by Georg Buss, who was heavily criticized by that time and who originally developed these techniques for transanal resection of polyps or early cancers. But he devised the knowledge about the anatomy and he also devised the technical skills how to treat the rectum from a transanal approach, and that was then again supplemented with what we learned from single port surgery, because by that time very many surgeons, at least colorectal surgeons, had substantial experience with single port surgery, so it was nothing new to them to work through a single port. And this is the setup for a modern TaTME, and given the scheme I showed you 2 slides ago with the 2 dissection lines, it becomes clear that the benefits of this procedure cannot be fully enjoyed when you only work with 1 team, but you need 2 teams, and that is one of the disadvantages of the technique as it is, because it requires 2 colorectal surgical teams. And here you see the setup at the Charité for a TaTME. It also requires 2 video units and quite large OR, and this in fact was one of the things which severely hampered the spread of this technique, because as a matter of fact very many colorectal units across the country simply do not have enough manpower to have 2 teams working for every rectal resection. Nevertheless, here we have some schemes of the TaTME, and you see the beginning of the procedure. The rectum is closed below the tumor, which holds the advantage that you can exactly define where you want to transect the rectum and define your distal resection margin. And you then open the rectum with the cautery hook. You transect the muscularis until you reach the fatty tissue outside the rectum, which is the lower part of the mesorectum. And once you've done that, you dissect within this part upwards, and using the air seal insufflator. And this is also something we had to learn. You can't use a standard insufflator because the small volume of air inside this port would lead to an enormous bulging every time the insufflator senses the pressure. But using the air seal insufflator and later technical developments like the insufflation bag from Applied Medical, for example, stabilize the picture, and you can nicely work into the mesorectal plane from below. And here, for example, you see this is the mesorectum. Outside you see the fascia covering the levator muscle, and when you proceed this dissection upwards, there comes the point where the team from above as well from below meet. And here you see the same patient with the transanal view and the view from above, and you see that the laparoscopic team is still working perfectly straight, while the transanal team is completing the resection, and you end up mobilizing the whole mesorectum from both sides, meeting in one plane. So this is the principle about the TaTME. And it had been quite early defined which patients might theoretically benefit from this operative technique. And again, you see that this was well thought of, because it is only patients with bulky tumor, with very low distal resections, with a narrow pelvis, or obese patients requiring a TME. So all patients where the tumor could be very difficultly accessed from above. And again, some benign indications also came along for what this technique is excellent. One is the proctectomy for patients with inflammatory bowel disease requiring an ilioanal pouch anastomosis, because using the transanal approach, you can be absolutely sure that there is no mucosal remnant left, which of course is important not only for IBD patients, but also for patients with FAP, for example. It's also helpful for high rectovaginal fistulas, and we also find it quite useful for patients who require colostomy reversal with a very short rectal stump, because everyone knows the situation when the ventral compartment has tilted backward and has more or less covered the rectal stump, which is not rare in patients with only the lower third of the rectum left in place. And for these patients, the colostomy reversal operation becomes much easier using this combined approach. And what is also important is that only by mobilizing the lower third of the rectum using the transanal route does not at all mean that you have to anastomose a patient with a coloanal anastomosis if you think that the patient doesn't benefit from that. So using this approach does not mean that you always strive for preservation of the sphincter, and you always keep in mind oncology. So you need to be radical enough. You can obtain a quite good quality. Actually, the Mercury classification, which goes from 1, which is perfect, to 3, which means some parts of the mesorectum are missing. The weight of 1 and 2 is above 95% using the transanal approach. And that has to be balanced against the function of the patient having a coloanal anastomosis. And of course, for some patients, it becomes obvious that he would not profit from such a deep anastomosis and then having more or less perineal stoma. So we had quite some patients by 2017, 3 centers combined the German experience. One was Berlin, and we had a 4% permanent colostomy rate after primary transanal resections. From the beginning on, we tried to collect these data in a retrospective registry, which was hosted first by Oxford and then moved to Amsterdam. There is a multi-center trial, the Color 3 trial underway, which compares the transanal TME versus laparoscopic TME. And we await end of accrual by the end of 2023. And then there will be a 3-year follow-up until we get some evidence from this RCT. These are the results published so far, and we also published our Berlin data, which were published by Luca Dietrich here, and you see that the rates are actually quite comparable. So the local recurrence rate is below 5% in almost all of the centers. The CRM positivity rate ranges between 2% and more than 10%, which I think needs to be attributed to patient indication, and which is what I mentioned in the slide before. You have to keep in mind that only by being able to preserve the sphincter should not endanger negative circumferential resection margin, and especially for very low tumors where the mesorectum has already finished, it's sometimes not meaningful to threaten the oncologic results. And this was one of the major blows to this procedure. You might have heard that 2 years ago, Norway stopped the TaTME because they did an analysis of the first 102 TaTME cases done at 4 centers. And they found that they had a 10% local recurrence rate, which is twice that being considered acceptable by that time. And they especially found some patients with multifocal recurrences, which were very difficult or impossible to treat. And they later on published their results of 10 patients out of this cohort with a local recurrence. And of course, you can see that some things need to be debated. First, when you look at the tumors and the distance from the anal verge, you see that they were not really the lowest rectal cancers. They were, however, locally progressed, and which is quite compelling is that only one of the patients had been treated by neoadjuvant chemoradiation, which at least in Germany would be considered absolutely standard for a locally advanced nodal positive tumor. And having in mind that now we talk a lot about total neoadjuvant treatment, you see that most of the patients would even require qualify for that. So they had these recurrences, and of course it was quite debated because to some extent the patients were not treated in an oncologically let's say following the guideline fashion, compared at least to standards of most countries. Nevertheless, the Dutch, which were very keen on TaTME, analyzed all centers which had contributed to the registry, and they analyzed the first 10 patients in 12 Dutch centers. And what they found, and this was quite alarming, is they found the same findings as the Norway group. And one of the clear findings was that the first 10 procedures had a higher rate of complications and local recurrences than once you had surpassed more than 40 cases. So they concluded that apparently there was a problem in the early learning curve, and it was quite interesting because they eventually pinned that down to 2 points. One was suboptimal patient selection. So for sure, many surgeons strive to preserve the sphincter at all costs, and eventually came closer to the tumor than they would have done before when they amputated the patient. And the second thing, and nobody had thought about that, was that the air seal, the insufflator, which allows a stable subpneumoperitoneum for the dissection, is working on a continuous circulation of air. And whenever the tumor compartment inside the rectum is not absolutely safely divided from the transection space, apparently tumor cells can be spilled and can be divided and spilled in this compartment. And this is how they explained the multifocal recurrences. And they further analyzed their cases and found that the initial purse string suture, which you saw in the very first video showing the at the beginning of the TaTME, seems to be of utmost importance, because if that is not correctly done, you have not a tight seal of the inner surface of the rectum, and this is very, very problematic using the air seal system. And once this had been realized, the local recurrence rate dramatically went down. But nevertheless, the data clearly indicate that this is the risk for local recurrence out of the Dutch experience. And you see that it is statistically significant whether or not you're a patient in cases 1 to 10 or between 1 to 40 or 40 onward. So this was certainly a finding that had not been taken into account, and which later led to distinct recommendations how to suture this purse string suture. And this is the current recommendation how to start a TaTME. So it doesn't make sense for small centers who have about 20 rectal cancer patients a year. It only makes sense if you have a team of at least 2 experienced colorectal cancer surgeons who can work together, and you need a hospital volume of about 20 low rectal cancers requiring a TaTME, and you have to take into account that your learning curve may be probably 40 cases or plus. So proctoring was also an issue, and taking together all this, it's hardly within the scope of most of the colorectal cancer centers in Germany and in Austria. And this is why the technique did not really lift up to become very widespread. When you look at the published experience worldwide, and we had this paper comprising more than 2,400 TaTME procedures, you see that the actual complication rates are quite low. The leak rate is quite appealing, and the conversion rate is really almost zero. But this is only the experience of centers who were large enough and had surpassed the learning curve and then published their data. So it's not the nationwide experience in Germany, where very many centers tried a couple of procedures and then stopped. And here again, you see what is the theoretical advantage of these new techniques compared to the traditional open and laparoscopic techniques. This is an interesting study from the Danish colorectal cancer group, again, a nationwide experience comprising 2,393 patients. And you see, you have open TME, laparoscopic TME, robotic, and TaTME. And you see the sphincter preservation rate is a bit better than it was in Germany, but still 25% for open and laparoscopic surgery compared to 95% for robotic and transanal surgery. The leakage rate is the same, and the conversion rate is 10% for laparoscopic surgery. Keep in mind, this is much better than the 15% from the Color 2 study, but it is only 5%, so half of that with robotic surgery, and it is almost nil in the TaTME group. So both of these techniques hold a distinct advantage over the laparoscopic or open technique in terms of these parameters. And there was an interesting systematic review comparing all available techniques for TME, open versus laparoscopic versus robotic versus transanal, and you see none of the procedures was statistically significantly better than the others concerning intra- or postoperative morbidity, conversion rate, reoperation rate, anastomotic leakage rate, local recurrence, R1 status, or 5-year overall survival. Nevertheless, robotic procedures had the least blood loss. Open surgery was the fastest. Postoperative morbidity was worst in open surgery and better for laparoscopic as well as robotic procedures. The length of stay was also reduced after robotic procedure, and the rate of incomplete TMEs, and keep in mind the MRI study was highest after open surgery, while the TaTME had a lower circumferential resection margin positivity rate compared to conventional laparoscopy. So the authors concluded that most of the relevant parameters were actually the same between these procedures. And they said that the selection of the technique should be based on the expected benefit of the patient and on the center experience. And another interesting thing turned out. When we started with TaTME, we were that thrilled by the excellent view of the pelvic floor and the nerve bundles of the Walsh bundle and the lateral autonomous nerves leading to the anterior pelvic organs, that we were sure that with the TaTME we would be better in terms of postoperative function. However, it turned out that when you look at LAS, low anterior resection syndrome frequency following rectal cancer surgery, there is absolutely no difference between the TaTME and the LAP-TME group. So the LAS rate, which is about, major LAS rate is about 30%. It's about 60% of patients in the first 6 months, and still about 50% after a year, is not better using a transanal approach. And the same holds true for all other functional scores. So this promise did not hold true. TaTME is not better in terms of functional preservation of the patient. So in conclusion, Does the TaTME make sense? Well, it is an effective tool for rectal cancer surgery close to the pelvic floor. We don't have class 1 evidence, as the RCTs are all ongoing comparing TaTME to laparoscopic resection, and we will have the results only in 3 years. TaTME, however, is technically demanding, has a very shallow learning curve, and might be advantageous for selected patients. However, you probably need to do more than 20 procedures a year on a regular basis to be really proficient with this technique, and therefore it only qualifies for very few centers, at least in a typical European setting. And this resulted in a not very widespread use, and parallel to that, robotic rectal cancer surgery emerged, and robots are spreading all over Germany and start to spread over Austria as well. So the pro and contra comparing robotic and TaTME is subjective and based on the possibilities of the center and the specific center experience. And in my opinion, TaTME has taught us a lot about low rectal cancer. Some interesting aspects arise from this technique, but I think this technique will further evolve and will more or less merge with robotic approaches, as I'm pretty sure that the transection from above is really advantageous using the robot. And then the only thing questionable is the determination of the distal resection margin, which probably might be a good indication for a transanal approach, but you more or less would only need to transect the rectum there and do not do much of a transanal transection upwards. So in my opinion, both techniques will probably merge and will be available as part of the armamentarium for treatment of low rectal cancer. So thank you very much for your attention. This was a brief overview from what we have learned about TaTME over the past 6 years, and I hope the talk was interesting to you, and I'm happy to take any questions. Thank you very much.
Indeed, the talk was very interesting. I'll start with a question myself. So in a case of low rectal cancer, would the best approach be the TATME, or like which procedure would you choose? Which is the best procedure for low rectal cancer? Is it TATME?
Well, as I said, in a setting where the TATME is trained, and we have some centers, especially in the Netherlands, they would clearly answer this question with yes. I think in most German centers, the answer would be no, because the centers are not trained enough. And then I would probably suggest robotic transection as low as possible if you have a robot available. Aside from that, if not, I think you have to acknowledge the color 2 data and say, well, if possible, a laparoscopic approach is beneficial and would be preferable if possible, keeping in mind that 1 in 10 to 1 in 8 patients cannot be operated fully laparoscopically, and then you would have to convert to open surgery anyhow. So for sure, the open surgery is always a part of the game in rectal cancer surgery, unless you have a robot or a TaTME, because then the conversion rate might be below 5%. Otherwise, it is certainly above 10%, and then you need to be proficient in open surgery as well.
Okay. Please, if you have a question, raise your hand. Dr. Medhat Khafaga. Unmute, Dr. Medhat. Yes, we can hear you.
Okay, you can hear me now?
Yes.
Yes.
Okay. Thank you for your lecture. Do you think that the announcement of those 12 cases done in Memorial Sloan Kettering Cancer Center with the monoclonal antibody for MSI high tumors is a game changer for you to adopt the same technique for rectal cancer?
Yes, the short answer is yes, I think, because I was actually surprised by the New England paper, because we have been treating MSI high patients for rectal or colon cancer for quite some while with a dual PD-L1 inhibition with nivolumab and ipilimumab, and the results are spectacular in terms of regression of the tumor, but we hardly see a 100% result. Nevertheless, I think that especially for MSI high patients, pre-treatment with immunotherapy could be really a game changer. Whether or not they they really all receive a complete remission, or that's what other data from the TNT concept say, probably 40% of patients will eventually not require rectal cancer resection. The results are spectacular, and I think that in the future we will see a multimodal treatment like the TNT concept for more and more patients, in which we could probably preserve the rectum by doing so, because, as I briefly said, 60% of the patients suffer from major loss after rectal cancer resection. So the functional results are problematic, and we will see what the long-term results are, but I think these data are very interesting, and probably for at least for the subgroup of MSI high patients, I think immunotherapy will be a part of the standard treatment in the near future.
Thank you.
We have another question from Hassan.
Yes, can you hear me?
Yes.
Yes, good evening. Thank you. This was really a comprehensive talk. I had a couple of questions. So is there a distance where you would prefer the transanal versus the robot or laparoscopic in terms of the distance from the anal verge, where you would, above which you would still think then the upper robotic would be preferable over the transanal? And then the next question about the organ preservation data that we are seeing more and more of in terms of the aggressive preoperative approach with chemoradiation or TNT approach and the complete response rates. Are you offering organ preservation to some of these patients?
Yeah, well, first question about the height of the tumor. I think as long as you can surpass the tumor with the robot, I think it's a very good way to work your way down to the pelvic floor. So this is one thing. And what I especially like about the TATME is that I can very clearly define the distal resection margin. So for tumors within 2 or 3 centimeters to the dentate line, I think you at least need to transect the rectum transanally to really define whether or not you're surpassing the tumor. And that circumferential transection of the rectum also leads to avoidance of the double stapling and thus an anastomosis in a purse string fashion, which I think is also better than a double stapling very close to the pelvic floor. This does not exclude a combined approach. You can always, if you have a robot and are proficient with that, of course, work your way down to the pelvic floor, but the safe transection close to the dentate line is then something which could be probably done best using the transanal approach. And actually, Antonino Spinelli from the University of Milano is one of the guys who has published several papers about exactly this approach. He did a lot of TATME and then switched completely to doing the dissection from above using the robot, and then transecting only the rectum through the transanal route. And this seems meaningful to me. So as long as you can firmly transect the rectum with a stapler from above and still fire an anastomosis above the dentate line, I think a sole transabdominal approach with the robot is meaningful. For anything below of 2 centimeters above the dentate line, probably a combined approach would make sense, I would say. And in terms of organ preservation, I think things are changing. We, in the past years, did not have good experiences with organ preservation. And now more and more patients are treated with total neoadjuvant treatment, and we get more and more data that a tumor regrowth within 6 months could be nicely detected. And if the patient regrows, the tumor regrows, it's mainly locally first. So I think that organ preservation will be a standard in the future. However, at least here in Austria, we are just defining what would be a good interval for surveillance. Presently, they have an MRI every 3 months, so that is also something you have to keep in mind. But I think the data indicate that at least a high percentage, and if you save the rectum in 1/3 of the patients, imagine what that means to the 1/3 of the patients. So I think that that it is worth a thought, and we are just defining all these scenarios. We are not quite there yet, so at the moment it's more or less an individual counseling of the patient and not a standard approach. But there's a very high interest in that, at least in the hospital I work.
And I guess ctDNA, some ctDNA data also could be helpful in the follow-up for these patients.
Absolutely, ctDNA is something which could be very helpful as a biomarker for better surveillance, and of course it would be a blood test, so it's easier than doing an MRI every time. So and you're absolutely right. These are also new tools which emerge and will help us aside from the traditional tumor markers which we had in the past, and we just know that close to 20% simply do not show any response to that.
Thank you.
Okay, do we have any other questions? Please, if you have a question, raise your hand.
I saw one question from the chat, maybe.
Okay, I still didn't see it. How do you deal with rectal mass above the peritoneal reflection?
Yeah, so that would be theoretically either if it's the
just
upper third
laparoscopic.
We would do a laparoscopic dissection, and if it's in the mid rectum, that would be ideal for a TME using the robotic approach, because then you certainly have enough space to staple from above. And you could do both. Actually, in the early experience in Berlin, we also did mid-rectal cancers with the TATME, which works perfectly. But you have to acknowledge that using the TATME, the patient always ends up with a very low anastomosis within 2 centimeters to the dentate line, which might not be necessary in a patient with a mid-rectal cancer when you require 5 centimeters below the tumor and the TME. And we all know that in some patients, the no man's land between the lower end of the mesorectum and the dentate line could be up to 5 centimeters. So I think that for mid-rectal cancer, the robotic approach, comparing these two techniques, would be perfect.
Okay. Any other question? Any question from the audience? Okay, looks like we're out of questions. And so thank you for joining us today. It was a very informative lecture. I'm sure everyone enjoyed it. And if you have time in the future, we're always glad to have you with us again.
Yeah, thanks for having me. It was a pleasure. And anytime, just stay in touch.
Do you have a question to the audience?
Yes, actually, if I may, because being here in Austria, there's really discussion about the use of the robot every day, and every hospital wants to have it. And I just would really like to know what you consider the value of the robot and how it is used in your country, because for sure there's very much of a hype going on right now, and as always with new technologies, everyone is enthusiastic about it, and it might well be that in a couple of years we see what we actually had seen with the past 3 generations of the robot, that it doesn't make much difference for very many operations, probably not for low rectal cancer. This might actually be a good indication for the robot, but for any other colorectal procedure, the data simply indicate it's the same. You can do it with the robot. Actually, presently in Austria, we are very much discussing that it's simply a technology change with all the younger colorectal surgeons will require to be trained on the robot, and therefore the system will stay, and for sure the technology will further evolve, but there is very much emotion in this discussion and not too much facts. So I would really be interested to hear about the situation in your country, if I may ask.
I think here in my country, the main limitation is the financial aspects.
Yeah,
we've had some experience with the robot before at our institute, but it didn't really take off. It didn't like achieve what it should have achieved. But right now I hear about many other hospitals, new hospitals buying the robots. So there is certainly a new trend that we will see more robots being offered here, but still the financial issues here are like here the patient, usually the patient has to pay for everything. So if it's laparoscopy, the patient has to like pay for all the additional costs and the ports and like it's not like a system, the system doesn't cover you. So most of the patients, they have to cover every aspect themselves. So I'm not sure if they would be able to choose the robot over traditional surgery or laparoscopy. It will be, the cost difference will be much higher, but let's see.
but that's a very true point, because we've done numerous calculations comparing robot to laparoscopic surgery, and it's always more expensive. So you really have to ask, do you have an additional benefit? Otherwise, it will not be affordable. Whatever system you're in, of course, if the patient pays it directly, it's a very direct way of regulating that. But even in public healthcare systems, it's simply not affordable to do every operation with the robot just because you can. So that will be eventually a pivotal question, I think, and we will see whether or not robotic systems become cheaper with more competitors in the future. If not, I'm very sure that the use of the robot will decline again, because
I'm sure in the future it will be less expensive. Maybe in like 10 years or something, it will be as cheap as laparoscopy.
Yeah, well, probably the techniques which come along with the robot, the bendable instruments, some sort of stable camera view, a nice 3D picture, all these things will stay. I think it's the same like with the mobile telephone. Everyone is using a smartphone now, and 15 years ago, everyone said, well, you probably don't need it, and you're probably right, but nevertheless, everyone has it. So I think the technique is here to stay, but whether or not we will use these full-blown systems for inguinal hernias, I'm not sure. Which actually is the greatest market in the US. So it's all about financial access. So if money is not that important, as I said, everyone does inguinal hernias with the robot because it works so well. Yes, I'm sure, but that's a key issue here in Austria as well. And it was in Germany. In Germany, actually, we were only allowed to use the robot for large cancer surgeries like esophageal surgery, liver surgery, or probably pancreas surgery. Not even for colorectal.
In prostate, I think it's also es lohnt sich in prostate cancer.
Yeah, well, in prostate cancer, that's right. For urology, the race is won. So I think there are some experts close to retirement who still achieve excellent results using laparoscopy or even open surgery. But at least from what I've heard from our urologists, it's just a generation issue, and everyone younger than 40 has never done a prostatectomy without the robot, and that's just resulting in a scenario where also in the future all urologists will work with the Da Vinci robot for prostatectomies.
Yes. Okay.
Okay. Thank you very much.
It was a pleasure. It was a pleasure having you, and looking forward to next time we can have you, or maybe invite you here in Egypt someday. That
would be my pleasure. Thank you very much, and have a nice evening.
Thank you, and good night, everyone. Good night.
Good night. Bye-bye.
Bye-bye.